Welcome to the Post-Acute COVID-19 Exercise and Rehabilitation Project, or PACER. This installment is Outpatient Physical Therapy Considerations for Post-Acute COVID-19. This will consist of 6 parts in a series, and today will be part 1 covering pathophysiology. First, a disclaimer. This course is intended for educational purposes, but does not replace mentorship or consultation with more experienced cardiopulmonary or acute care colleagues. Content is also current at this time, but realize that the evidence and the science on COVID-19 is evolving rapidly and may change. A little bit about myself. My name is Mellett. I'm a board-certified cardiovascular and pulmonary specialist, and I'm the past treasurer of the cardiovascular and pulmonary section. I work at Brigham and Women's Hospital in Boston, Massachusetts, in their Foxborough ambulatory location. I work primarily in their outpatient cardiac rehab program, but I also work individually with patients who have a variety of pulmonary and cardiovascular conditions. I'm also adjunct faculty at Northeastern University in Boston. And I have no disclosures. Before continuing, I'd like to give a special thanks to the following colleagues for giving vision and assisting in the creation of this COVID-19 series: James Zakazewski, Angela Campbell, Talia Pollock, James Spencer, Sandra Norby, and Jessica Riggs-Garten. Thank you very much. The objectives here is that by the end of this 6-part COVID-19 series, participants will be able to describe the virology, symptoms, clinical course, and acute care complications of COVID-19 infection. They'll be able to explain the rationale guiding decisions on discharge disposition after COVID-19 hospitalization and how it will influence outpatient physical therapy presentation, apply effective infection control practices to the outpatient physical therapy environment, understand and address impairments and limitations related to COVID-19 illness and post-intensive care syndrome, or PICS, to identify novel COVID-19 therapies, to interpret lab values specific to COVID-19 illness, and to evaluate and treat patients that are referred to physical therapy status post-COVID-19 infection. So to start with a little background on COVID-19 emergence, we've seen viral epidemics over the past 20 years, starting with severe acute respiratory syndrome coronavirus, or SARS-CoV, in 2002, H1N1 in 2009, and the Middle East respiratory syndrome, or MERS coronavirus, in 2012. Coronaviruses are common in animals such as camels, cattle, cats, and bats. In these cases, it has been animal-to-human transmission. The current coronavirus, or SARS-CoV-2, was originated in Wuhan or Hubei province, China, back in December of 2019. This was a new illness presenting as a, quote, pneumonia of unknown etiology, possibly linked to wholesale fish and live animal markets. The thought is that the coronavirus originated in bats and then was passed to a pangolin, which was a mammal that lived in the China region, and then that was passed to humans. This coronavirus is highly contagious. It was spread to 18 countries by January 30th of 2020. It was formally named SARS-CoV-2, or SARS coronavirus 2, and COVID-19, which stands for Coronavirus Disease 19, standing for the year 2019 in which it originated, and that was named on February 11th. And then the first case was recorded in the United States on February 26th of this year. Looking at the virology, this virus is a beta coronavirus. It's of zoonotic origin, meaning that it comes from animals such as bats and rodents in this case. It may cause respiratory, enteric, hepatic, and neurologic diseases. It's an RNA virus with a crown-like appearance due to the spike glycoproteins, as you can see in the picture on the right. It uses the angiotensin converting enzyme 2, or ACE2 as we call it, the receptor for cell entry. Now this ACE2 receptor is a membrane protein, and it's expressed in the lung, the heart, the kidney, and the intestine, and then some other areas in the body. This ACE2 receptor is also abundant in type 2 alveolar cells in the lung, which we will see in the future slides. The coronavirus binds to ACE2 with a 10 to 20-fold higher affinity than the original SARS coronavirus. And once this RNA virus gets into the cell, it takes over the cell's processes, and then it replicates itself to continue to invade new cells. Transmission is mainly person to person through respiratory droplets. Coughing, sneezing, talking, all of those things, and if droplets make direct contact with another person's mucous membranes, then that virus can be spread. Respiratory droplets typically travel less than 6 feet and don't linger in the air necessarily. So this 6-foot distance in terms of social distancing is based on this. The virus can also be spread by touching infected surfaces and then touching the mouth, nose, or eyes. However, more recently, it's been found that the risk of transmission through the infected surfaces has been a little bit lower than previously thought. COVID-19 is sensitive to ultraviolet, heat, and most liquid solvents and disinfectants, which is why washing hands and using hand sanitizer is effective. It is viable up to 72 hours on plastics and stainless steel, 24 hours on cardboard, 4 hours on copper, and one study has shown it to be detectable in the air for 3 hours. However, keep in mind that these studies have been done in a laboratory in a closed system and may not necessarily represent the exact transmissibility in day-to-day life. It is inconclusive about airborne or aerosol transmission, although airborne precautions are recommended for aerosol-generating procedures. And viral RNA has been detected in urine and feces, but there's no evidence of transmission via this route or in water or sewage. Additionally, spreading the virus from people to animals or animals to people, that risk of spread is also low. The incubation period for COVID-19 is up to 14 days. However, most people experience symptoms within 4 to 5 days after exposure. The virus levels are higher before and soon after symptom onset compared with later in the illness, which is why patients can be asymptomatic and not know they have the virus and be at very high risk of spreading it early upon transmission. The risk of transmission varies by type and duration of exposure, use of preventive measures, and individual factors. In fact, the risk of transmission has been higher within household contacts, in congregational or healthcare settings without personal protective equipment like hospitals or long-term care facilities, nursing homes. Transmissibility is higher in closed settings such as cruise ships that we've heard of, and then also in some social gatherings where it's more difficult for people to distance each other. People who are asymptomatic may still transmit the virus because there is still a high degree of viral shedding from the upper respiratory tract, even if a patient is not having any symptoms. It's uncertain as to how long a patient remains infectious. Viral RNA may be detectable in the upper-lower respiratory tract for several weeks after illness onset, but it doesn't necessarily mean the infectious virus is present. And in fact, we don't know for how long a person is going to be infectious. And the risk of reinfection is really not known after recovering from COVID-19. So there is some evidence that antibodies are formed, but how long this protection lasts is still unknown. Once a person contracts COVID-19, or the SARS coronavirus 2, if it reaches the lung, it binds to the ACE2 receptor on the surface of the pneumocytes. These pneumocytes are type 2 pneumocytes, which line the alveoli, and they release surfactant, which is responsible for preventing collapse of the air sac or the alveoli. As a response to this, the white blood cells rush to the alveoli and release inflammatory chemicals. Once this occurs, because of the inflammation, the blood vessels or the capillaries that are surrounding the alveoli become very leaky in response to this inflammation and in response to the chemicals, and this fluid causes more pressure to be put on the alveoli, And in combination with loss of surfactant, it causes those alveoli to collapse and become destroyed. The initial symptoms of the virus, and the most common are bolded here, are fever, cough, and fatigue. The cough is usually dry, but in a minority of cases, or about 25% or so, the cough can be productive of sputum. In addition to fever, cough, and fatigue, there can be shortness of breath or difficulty breathing. And this usually occurs at least 8 to 10 days into the illness if that's going to happen. Myalgias or muscle aches, chills, sore throat, headache, and a new loss of taste or smell. There are other symptoms that have been reported, but they're rare, such as diarrhea, nausea, abdominal pain, nasal congestion, conjunctivitis, hemoptysis, which is blood in the sputum with coughing, a skin rash, or finger-toe discoloration, also known as COVID toes, which will be discussed later in the presentation. The majority of cases of COVID-19 are mild at about 81%. With mild, shortness of breath is usually not present. Mainly, it presents as an upper respiratory infection with either no or only a mild pneumonia. It can be severe in about 14% with dyspnea or shortness of breath, a higher respiratory rate of over 30 breaths per minute, hypoxia with an oxygen saturation less than or equal to 93%, and or lung infiltrates in over 50% of the lung within 24 to 48 hours. And the critical cases, or about 5%, which are a small minority, show respiratory failure, septic shock, and or multiple organ dysfunction or failure. And severe includes the diagnosis of ARDS, or acute respiratory distress syndrome. Some of the risk factors for developing the severe illness would be an age greater than 65 years old, hypertension, diabetes, cardiovascular disease, severe obesity, chronic lung disease, moderate to severe asthma, chronic kidney disease, usually patients that are on dialysis, cancer, those that are immunocompromised, liver disease, cerebrovascular disease, tobacco use, and those residing in nursing home or long-term care facilities. In patients who do contract COVID-19, some common lab findings include lymphopenia, which is a reduction in lymphocyte count, which is a subclass of white blood cells, elevated liver enzymes such as ALT and AST, elevated lactate dehydrogenase, which can be a sign of muscle damage or inflammation, and elevated inflammatory markers such as ferritin, C-reactive protein, ESR, which is erythrocyte sedimentation rate, and interleukin-6. With severe illness, it is more common to see an elevated D-dimer, which indicates that there's clotting occurring in the body, elevated prothrombin time, elevated creatine phosphokinase, again indicating some muscle damage potentially, elevated troponin or the NT-proBNP, both of which can indicate myocardial injury, and acute kidney injury. Imaging findings are mainly chest imaging, which would consist of a chest radiograph or X-ray, and in early or with mild disease might remain normal. Or if disease is a little bit more severe, might show consolidation indicating pneumonia, or ground glass opacities, which also could indicate pneumonia and inflammation in bilateral, peripheral, and lower lung regions. A chest CT can also be helpful in showing ground glass opacities with or without consolidative abnormalities, and this would be consistent with a viral pneumonia. Lung involvement tends to increase over the course of the illness, with a peak in severity at about 10 to 12 days after symptom onset. And as you can see here on the left is an example of a chest CT where the red arrows are, you can see subpleural ground glass opacities in those hazy areas of pneumonia. And on the right-hand side is a chest X-ray showing multifocal areas of patchy consolidation, which would also be indicating a pneumonia. We know that The majority of COVID-19 cases are mild, but the minority can go on to become critically ill and develop acute respiratory distress syndrome, or ARDS. And this is the most common finding in those that are critically ill, in about 60 to 70% of them. These patients are older and they have more comorbidities. Now on the right-hand side of the slide, you can see the diagram of the split version of the normal alveolus on the left and the injured alveolus during the acute phase of illness on the right. So as you can imagine, all of that debris and all that inflammation and fluid is going to impair gas exchange significantly to the point where the patient may require mechanical ventilation. And in fact, mechanical ventilation is required in about 42 to 100% of those patients who have acute respiratory distress syndrome. And this typically has a poor prognosis with a mortality rate of 52 to 67%, and the highest death rates occur in patients who are at least 64 years old or older. One proven therapy in ARDS is proning, and this is being widely used in patients who are in the ICU with COVID-19. And the benefits of proning include improved ventilation perfusion matching, which is where the areas of the lung that are getting the best aeration or ventilation are matching up better with the areas of the lung that have the best blood flow. And this results in reduced hypoxemia, so that you are getting more oxygen into the blood and more oxygen delivery to the tissues of the body. Another thing that proning helps with is recruiting the posterior lung segments by reversing atelectasis. So normally those posterior lung segments are below the organs and the abdominal tissue, and tend to get compressed and can develop atelectasis. So by having the patient lie in the prone position, this area of the lung is now above and does not get as compressed and can aerate better. Proning also helps with improved secretion clearance. Some advanced supports that you might see that your patients might have gone through are having pulmonary vasodilators, such as nitric oxide or some of the PDE5 inhibitors in order to improve blood flow to areas of the lung. Neuromuscular blocking agents because of being intubated so that they are tolerating the ventilator better, and extracorporeal membrane oxygenation, or ECMO, which is a large system that helps oxygenate the blood for the patient. Some other complications of COVID-19 that might be seen in the critical care setting would be sepsis, which is the body's overreaction to infection and can result in systemic inflammation that can lead to shock, multi-organ failure, and is associated with increased mortality. If it progresses to septic shock, it may require vasopressor support for hypotension. This is connected with inflammation, and inflammation, when it gets out of control in the body, can result in what's called the cytokine storm, which has been what's responsible for a lot of the multi-organ failure and shock that we're seeing in patients with COVID-19. We can also see acute kidney injury caused by hemodynamic changes in cytokine release, but it could also be due to direct cell injury by the COVID virus itself. And this may cause the patient to require renal replacement therapy or dialysis due to the kidneys being so damaged. And finally, we can also see elevated liver enzymes, which can be due to the body's immune response, or it can be due to the COVID virus directly linking with liver cells because they also express the ACE2 receptor that the coronavirus likes to attach to. And then also elevated liver enzymes can be drug-induced. Cardiac injury is usually a late complication of COVID-19 in the ICU, manifested possibly by stress cardiomyopathy, which would be diagnosed via echocardiogram, myocarditis, which is an inflammation of the heart muscle tissue itself, atrial arrhythmias, the most common being sinus tachycardia, but we may also see atrial fibrillation, atrial flutter, ventricular tachycardia as well. Myocardial infarction, We see elevated cardiac enzymes in a lot of patients who have COVID-19, and the myocardial infarction may or may not occur in patients who have pre-existing coronary artery disease. They've found that there are many patients who have had so-called clean coronaries or no evidence of coronary disease that have gone on with COVID-19 in the ICU to actually have a heart attack. And this is thought possibly to be associated with the increased hypercoagulability that we'll see on the next slide, or just the systemic inflammatory response. And other manifestations may be sudden cardiac death and heart failure as well. And if you look to the right of the screen, although it's a busy diagram, that's just a schematic for looking at the different mechanisms of myocardial injury. Hypercoagulopathy has also been an issue in the ICU for patients with COVID-19, manifesting as DVT or deep vein thrombosis or pulmonary emboli. DVT has been found in up to a third of patients with COVID in the ICU, even when prophylactic anticoagulation is being used. It is thought potentially the hypercoagulable state is associated with the acute inflammatory changes or the cytokine storm that's associated with COVID. Autopsy studies have shown microthrombi in the small vessels of the lungs, the heart, liver, and kidney, also suggesting systemic coagulability. And this has also been associated with elevated D-dimer, fibrinogen, and other prothrombotic factors. Some neurologic complications include encephalopathy, which may manifest as agitation, confusion, or hyperreflexia, delirium in the ICU, and also ischemic CVA, which might be a result of the hypercoagulopathy as well. This marks the ending of Part 1, Pathophysiology, of the series Outpatient Physical Therapy and Post-Acute COVID-19. Here are some of my references if you would like to learn more details on any of the topics previously discussed. And here are some helpful links for further information on COVID-19 and its pathophysiology.